In the DBT world, we often focus on behavioral change and skill acquisition, sometimes with an assertiveness towards push towards growth. And in the trauma world, the emphasis tends to be on safety, stabilization, and pacing, ensuring clients feel safe enough to begin exploring change. But it doesn't have to be so bifurcated. In Marsha Linehan's seminal work, Cognitive Behavioral Treatment for Borderline Personality Disorder, she laid the framework for what is now called DBT, a modality built on holding two truths simultaneously. This emerged from her own healing and became a way to help people who were suffering deeply in a way that was both behavioral, evidence-based, and profoundly validating, but also scientific and spiritual. That spirit of integration is what we're here to explore today. Our hope is that this panel will open up dialogue where these models differ, where they align, and how they can complement each other in practice. We'll talk about the concerns trauma-informed clinicians often have about DBT. It can often feel too fast and too pushing. And on the other side, DBT clinicians' concerns that they express that the trauma frameworks can sometimes overemphasize fragility and stall growth. By the end of our discussion, we hope to land in that dialectical gray, as I like to call it, where behavioral change and deep validation can coexist, and where clients can both feel safe and move towards meaningful growth. So I want to first welcome our esteemed panelists. We have John Ifrah, my own personal supervisor for the past 3 years. John Ifrah has been practicing as a clinical social worker for the past decade. He works at Machon Dvir providing individual and group psychotherapy, as well as in a private practice treating individuals and couples. He also participated in Israel's first EMDR 2.0 intensive for complex PTSD, founded by Rachel. He holds advanced accreditation in individual schema therapy and utilizes an integrative approach to psychotherapy, drawing upon behavioral, experiential, and psychodynamic modalities. All the way on the other side, we have Dr. David Haplern. He's a child, adolescent, and adult psychiatrist in Israel and the United States, and he integrates DBT, psychotherapy, and medication management in his work with teens at Beit Daniela and in his private practice. In the middle, in the red, we have Dr. Rachel Rashkin. She's a US-trained clinical psychologist, supervisor, author of 3 books, and accredited EMDR and EMDR 2.0 clinician. She teaches experiential workshops on topics related to complex trauma to clinicians of all levels, and is responsible for bringing the EMDR 2.0 intensive treatment to Israel under Merkaz Omakim, which treats PTSD and complex PTSD in adults 18+. Lastly, but not least, we have the esteemed Shevi Slome, who's my new supervisor, actually, LCSW, and she leads DBT skills groups and provides individual psychotherapy and coaching at Machon Dvir. Prior to moving to Israel in 2020, Shevi worked as a clinical psychotherapist at Achieve Behavioral Health, a mental health clinic in Muncie. Shevi was also a DBT group leader and a DBT individual coach for Achieve's intensive outpatient program, a trauma-informed comprehensive treatment program led with an emphasis on mindfulness, SE, CBT, DBT, ACT, all of the other acronyms, as well as family therapy. Okay, any questions before we start? Let's start. Okay. I'm going to ask for all of you to just keep your responses 2 to 3 minutes. I don't want to have to cut you off. That gets awkward. Okay, so keep your own time. And keep in mind that if anyone has any practical questions, you can either ask them now or we can save them for the next session, which is going to be more of like a role play and case conceptualization. Okay. This is our first question. I feel like I'm on Jeopardy. DBT often pushes towards change while trauma-informed care can focus on safety and stabilization. How do you hold both of these priorities in your work, promoting growth without compromising safety? I'd love to hear how each of you think about holding those 2 priorities in your work. And even against, Rachel, even though you're not a DBT clinician, how does this, apply to your work? How do you hold safety and stabilization and as well for you all? Whoever would like to take the question first.
All right, 2 minutes, go. Okay, so touching back on the previous panel, actually. So as the psychiatrist, you're trying to balance both pushing your patients forward and safety, right? If the buck stops with me legally, so that's something that you always think about. But I tell people, especially here in this country, there is no way to practice outpatient mental health treatment and see patients who should require either trauma-informed care or DBT, and not be willing to understand that there will always be a level of mild to moderate risk for your patients because they may do something that is beyond your control. We cannot control our patients. We can only help guide them and help protect them as much as possible, what's appropriate. In general, I usually tell people that I'm here to help you find the tools. I'm here to help, oh, look at that. I'm here to help you find the tools to help yourself improve. If I ever give anyone the impression that I'm going to help fix them with something I'm going to do, whether it be a medication or a therapeutic intervention, that's usually not a good idea. Like, I really want the patients to be able to say, I am myself gaining skills or gaining some independent feelings, whether in whichever modality they're using, that allows them to move forward. And so if they need time to process, that's fine, but I say that there has to be a definitive set time for that. Meaning, if let's say someone comes as an adolescent psychiatrist, you're in 10th grade, if I give you the time for safety, that means you're going to miss your whole year of high school because you were planning on slowly processing your trauma, which that's a debate that people can have. I'm a strong and firm believer in setting a time period that you have to work within that framework. So as long as you've set that up, then you can use both of those models together. But if you don't have an idea of when it's going to be and it's indefinite, so then things can go on and on for a very long time and you don't see the progress that you need.
I think that, like, when I heard this question and read it, what came to me was the word enough. And to Rachel's credit, we learned this together under her leadership, that you're not looking for perfection from a client. You're looking for safe enough and for them to change enough. And that in itself creates a lot of beauty in the room. And it's a dance. It's you take 2 steps forward towards safety, and then you can take 2 steps forward towards change. And it's not linear, and you can move in the change direction and find yourself going back to reintegrating safety and then segueing back into change. And that ability to ebb and flow is something that takes a lot of work on our part as clinicians to read the room well, read ourselves well, how we mirror. So it's not really a contradiction. It's the beauty of a dialectic where we live with both of those truths together in the room all the time. There's never a time where safety is not of a priority in the room, and there's never a time where change is not a priority. And we're looking at both with the same relevance and same importance. And I think if we believe that both are primary in the room, then that's where change happens. Where if you believe a client is safe enough, you could push them in the direction of change, even though you might be really rattling them, even though there's a lot in the room and there's a lot going on, there's a lot of energy and a lot of dysregulation. There's the belief that you could do this. You have the ego strength. I know you could do this. I know you have the capacity. So there's safety there, and I'm relying on that safety in order for you to change. So it's not really either or. There's an and here.
Okay. Thank you for that shout out. I think also I'm going to just answer the question from a little bit of a different angle. I think we put a lot of pressure on ourselves as clinicians to create a safe space for our clients, and safety looks and feels different for different people. For some clients, safety is going to be the silence that you allow to be in the room. For some clients, safety is going to be them acknowledging that you're not colluding with their avoidance, and that feels really safe. So it looks and feels different for everybody, and a lot of it is just intuitive. It's the vibe we bring into the room. It's the energy we bring into the room. It's our active listening skills. It's our ability to be attuned. But I also want to mention, which maybe is a little bit less talked about, I'll sometimes tell supervisees who are saying, I'm having difficulty creating a sense of safety in the room with my client. And yes, of course, we look at content, we look at what's going on dynamically, but also for the therapist to look at him or herself and to sometimes ask yourselves the question, how safe am I feeling in the world? How safe am I feeling right now in my relationships? How safe am I feeling in my body? Those are really important questions to ask. How safe and comfortable do I feel with high levels of activation in the room with my client? How safe do I feel allowing my client to leave the session perhaps in a more dysregulated state? We tend to like to wrap things up really neat in neat and tidy ways, and we don't want to see our clients leave in tears or angry or silenced. But that's usually more about us than it is about the client. So those are also important things to think about when we're talking about safety. It's co-created. It's a co-created dynamic.
So I'll just echo what both David and Shevi had mentioned, that there's no guarantees. Right? There's no way of guaranteeing that clients will stay in a safe spot. Part of it is a risk, and we don't have control over their behavior. The most that we can do is offer help, and that's limited. So that's always a factor. And like Shevi had pointed out, it's not linear. So it might be that the client feels safe enough to you to move on now, and then you reach for that change, and then something else opens up that was not anticipated, and then you have to go back again to safety and stabilization. I also see safety itself and stabilization as change. I don't really see them as distinct categories. Somebody who's now choosing to use DBT skills as opposed to cutting, that's a major change. So it's about safety, but we're trying to help them find more adaptive ways of coping and substituting the old maladaptive ways. So I really see them as overlapping.
Okay, what I'm hearing from all of you is that that's sort of a dance, and within the therapeutic, space, we have to see our client obviously as the totality, the total parts of who they are, and that means recognizing what they're able to do. If they're in school, if they have a job, what their needs are, and therefore that informs what kind of work we do, and then also just obviously holding that dialectic and that of seeing that client for all of their parts. What are their safety needs, as Rachel was saying? What actually does that look like? And then obviously looking inwards and saying, and what role am I playing in this? And what does safety actually mean? Which we'll get to soon. I want to start with Dr. Haplern, and you guys can all address it if it feels relevant to you. But when you have a patient come into your office, and obviously, oftentimes psychiatric medication, coincides with therapy. How do you decide what kind of therapeutic modality is right for them in that moment?
All right, so I'm going to argue with you. Okay. I don't decide what kind of therapeutic modality is right for them in that moment. It's because I'm not going to see them in that moment. Whoever they see for therapy isn't going to see them in that moment. In that moment, they might be dysregulated. They might be either someone who's ambivalent about seeing me, who's angry at the fact that they have to see me, who is hoping that I'm going to save them. Lots of different thoughts and feelings. In general, I try to be as evidence-based as possible, right? So when someone comes in, I see essentially all ages. So when a child comes in, I'm not thinking of the same types of therapies I'm thinking for a teenager, as a young adult, as an older adult, as in any stage of life where someone's in, but it also depends upon what their cognitive capabilities are, because even if somebody's IQ is normal, if they're not used to the world of therapy, that's a good example. I see a lot of patients from many different worlds. I practice in Ramat Beit Shemesh, and there's people from all over that come. There's not a lot of psychiatrists apparently, but the general way that I view it is when someone comes in, if they give me a story that tells me that they meet the criteria, the DSM-5 criteria, and it can be from a million different reasons why they meet the criteria. This is not saying that one diagnosis fits. One diagnosis can fit many people, but where the etiology is very different. But if they meet the criteria for that diagnosis, then the evidence shows that there are certain therapy modalities that are the first line options for those things. So the majority of time, I will usually recommend a CBT style treatment if it's the first time someone's asking me for therapy, just because the percentage-wise, the number of people who are coming in with a MDD or GAD diagnosis after an evaluation is higher. At the same time, there's usually, if someone's already coming to see me, in Israel for sure, by the time you make it to the psychiatrist, usually you don't just have those two diagnoses. You get I call it the laundry basket of things, and trauma is almost always included in that. And so then the treatment modalities become more complicated depending upon what's happening. DBT is definitely very high up there on the list of things I would like to recommend. I would point out to everybody here, because I know this is something that I hold dear to my heart, DBT-informed therapy is not the same thing as DBT therapy formally in the studies, per the evidence base. So it's just something we have to be aware of. DBT-informed therapy is still evidence-based and still can work. But if there are clients where DBT-informed therapy is not working, if anybody has any of those clients, it would be a great time to take a step back and be like, if the therapy is not working after the number of sessions that it's supposed to work, that's a really good time for me, I always ask when they come back to see me. Often I'm not doing the therapy, but they're coming back to see me. They only have seen me twice. It's been 2-3 month periods of time. And I say, okay, well, you're still in this same position. They don't want to do a medication change, and they're stable enough not to do a medication change. And I say, okay, great. So then what's the plan? I mean, what do you mean, what's the plan? I'm working in therapy. I said, well, that's great that you're working in therapy. Therapy is a long-term process, but depending on if someone's in psychodynamic psychotherapy, so then I'm going to say that's fine because it's a much longer time frame in terms of supposed to seeing a result. But if somebody is in a very identified type of therapy, CBT, IPT, any of those sorts of therapies, there's supposed to be a definitive timeline for when you're supposed to improve. So if there's specific reasons why not, that's great, but they should know that. Like your client should know that if there's a reason why they're not there. So that's really how I assess it usually when someone comes in. If you have to weigh when trauma is there, how much of the trauma is ancillary and how much of it is a source. Because a lot of people in this country, everybody has traumatic stories. Right? I work in the Beit Daniela program in the South, right? And there's every kid there experienced the war. The question is whether or not has the war become the basis and things are built on that, or is it that they have other things that were there the whole time and that they get a plus, they get bonus war on top, right? So then, but the therapy modalities are different. Right? CBT with a trauma-informed perspective versus an actual, like, going to the trauma first and then process things afterwards is important. So that's the general, I would say, gist of how I approach it.
You pass it on to Shevi. I'm going to ask you sort of to go off of that, which is when a client shows up in your office and the information that you're receiving makes sense to do, a very specific DBT protocol with the client. How do you sort of hold that, which is, very didactic, there's a very, specific protocol which we're familiar with to impart or to work with together. How do you sort of hold that with the fact that they're coming in with all of that trauma? You hear it in the intake. And that's a lot to hold, where there's, the pragmatic stuff that we have to get through and the diary cards and behavior chains and all of that, with holding space for the fact that, okay, but there's a person in front of me.
That's a really good question. I think to put the client first and your agenda aside is what we have to focus on before anything. You will come with an agenda, especially when you have multiple referrals from this client and the psychiatrist has reached out and this has reached out and there's a lot of people who need you to see this person and they're sitting in front of you. They're a human being, first and foremost. And when you're doing that intake, that is what you're trying to understand. Who are you? What are you bringing to the table? What about you don't I know or do I know? What is implicit and explicit? What are you communicating to me? Yeah, how do you develop in every matter? Physically, emotionally, developmentally, how did your nervous system develop? Who is this person in front of me? Who is this human being here? And when I approach that with empathy and validation and connectedness and create that safety from the get-go, then there's room to give psychoed about what is DBT, because there's so much out there that people hear or know or read up on DBT that really scares them and gives a sense of lack of invalidation. It completely pushes their trauma away and their humanness aside. And what we want to do first is if you approach them as a human being in front of you that you're genuinely curious and open and mindful of getting to know, then there's a relationship. And when there's a relationship, there's anything. Like you could do anything when you have a relationship in the room. And when that happens, then you can start to melt the ice, right? And when the way I start and introduce DBT in such an instance would be, you're holding an axe and you're telling me your life is hell and it's not worth living and you want to die yesterday. And then you're telling me you also want to build a life worth living but it's not really worth it. And you're contradicting yourself in the room. So why should you live, right? You're holding that axe in your hand. And I'm trying to sell life to you. It's just not going to work. So the first thing I'll do is, can you put the axe next to you? Like there's an empty chair. Can you put the axe down, right? Like let me just get to know you first. And then we'll figure out whether you should live or not. And the second you can approach them from that place, like let me just put your 2 feet in the room, right? Like, can you just sit in the room, take a deep breath, let's just hold space here, right? When there's the relationship there, there's something to work with. That you're on their team. You're not another treatment provider. You're not out to get them. You're not holier than them. You're not more knowledgeable than them. You're just joining them. And you become a team together. And you can work through anything that way. So then DBT becomes something that is accessible and can be worked through.
I just wanted to add something to that. So yeah. So my like I was giving more of like the clinical piece, but I 100% agree. There's zero benefit to any intervention without the person feeling like you want to understand who they are. Like if they don't feel if your client does not feel that you understand them, then it's the whole piece becomes relevant because then you're working on a machine. And I tell people all the time, like if you wanted a vending machine, you could go see somebody else. There's a vending machine. Unfortunately, sometimes some kupot in certain places may be considered vending machines. Chas v'chalila. But the idea is that that's how it is, and we want people to understand that they really want to like have that connection with someone, and having them see like, oh, this person understands me. This person is not coming in and saying, I know better than you. I know exactly what's going to be. It just doesn't work. Before I give any recommendation, I give people a little spiel, where I say that the Mishnah says, Tov sheberofim legehenom, the best of doctors go to hell. And that I interpret that to mean I'm not facetious enough to think that I can meet you for one session, and then now I definitely know who you are, and I'm going to tell you exactly what's going to be, and it's going to work. It just doesn't happen. But this is what I do. And so I'm going to use the tools that I have to tell you what I think makes the most sense, and I'm trying to understand where the things that are causing you the most distress, where those things may be coming from. And just saying those lines is enough usually to have people recognize that like there's something more to this person, hopefully, if I'm not faking it, okay? There's something more to this person that he wants to actually like see who I am and help me. And so that's one of the magical things.
Yeah. And anecdotally, they read the room really well. So if you're not genuine, you're out of there. You're fired. Like in a second, they know. Like, oh, where did you read that? Where did you learn that? What book told you that? You know, just like that was so not genuine. Like, who are you? Who is this person? They just want to get to know you in your rawest and deepest sense, that you really deeply care about this person in front of you.
Or the whole "how can you care about me if I'm paying you" type thing, right? We've all got that one. Just to add quickly, all good stuff said so far. The one consistent piece of research we have over the last several decades in our field is showing, right, that it's the relationship that really transcends all the modalities that are out there. It has to be a prerequisite. You know, we would be best to thank Carl Rogers and some of our others for really giving us those basic ingredients of what goes into making therapy successful. Most of the positive outcomes, I mean, people will say, you know, it's not your brilliant interpretation that they remember 10 years later. You know, it's not your go with that in EMDR that they remember. It's the way that you greeted them. It's the cup of tea you poured for them. It's the way that you remembered their doctor's appointment and asked about it. Those things matter to people, and people remember those things years and years after therapy ends. So.
I'll just add one thing that came to mind, which is I don't see this question as being a uniquely DBT-oriented question. I think that with all psychotherapies that have protocol to them, whether it be EMDR, DBT, discerning ACT, CBT, that there's always this delicate balance between how much do I stick to the script and how much do I allow the process to unfold. And I really do think that it's a balance. We've spoken before about this idea of the art and science of psychotherapy. So there is an art of being in the room and allowing things to unfold and being present with the other, you know, like Rogers places such a heavy emphasis on. And there's also something about, David, you were talking about modality-specific treatment. If somebody's coming in with depression or with anxiety, what makes the most sense over here? And I think it's easy to get lost on both sides. I imagine it has to do with temperament as well. Going back to Tzachi Fried's presentation, people that are more over-controlled might have a harder time letting go in session and being more scripted or referencing protocols in their mind and trying to connect all the dots. And people perhaps who are more under-controlled, it might be more of a challenge to sort of consolidate and bring things in. And I think it's easy to fault on either side, and the art of it is finding that balance.
Just to that, I'll go off to give that to you, John. I can speak loudly. It's okay. How do you feel like you're able to create that space within, if you're talking more about a DBT framework, to create that safety within the space and within the protocol? And obviously, there's that. Can you just explain a little bit more what that art and science looks like for you when you are conducting the session?
Yeah, that's a good question. Maybe this itself is a little over-controlled, but I usually like to.
Take care of it after.
All right. I try to leave at least the first 10 or 15 minutes open just to see what comes up. So if I'm practicing in a DBT informed, perhaps, sort of way, which is awesome. If somebody's coming in, somebody's suicidal, and I really want to stick much more to the DBT script. So I don't want to leave the 10 or 15 minutes open. If I look at their diary cards and there was any sort of high-risk behavior, and that takes precedence, and I'll jump right in. So then I won't leave those 10 or 15 minutes. I guess it's sort of a luxury to have that, assuming that the person doesn't have something that's more explosive, but assuming that they don't, and I think most people that I work with are not coming in, highly suicidal, into every session, then leaving over 10 or 15 minutes and just seeing what they're bringing in and being curious and open to what they're bringing in. Sachi and I have spoken about this a lot, the danger of sort of superimposing one's agenda on the client. And like David and I think Shevi were both speaking about, they'll read it, they'll feel disconnected, and it's going to be a no-go. And I think that's true for all of us. Or if we're talking to somebody and we're there for help, and we have this sense that, I was once observing people talking in the park, and it was like a group of women, and I noticed that nobody was actually listening to anybody else. One person would talk, and the other ones were like waiting until somebody else was finished, and then they could say what they wanted to say. But it wasn't a real conversation. It was just everybody, and it worked in that context. But I think that we all appreciate and we all like it when we are heard, and when the other is interested in us. So, I'm sorry?
In and out of therapy.
That's right, in and out of therapy. That's how I think good relationships, healthy relationships work. So again, giving that time to allow things to unfold. Where is my client walking in right now today? Listening, I guess, more psychodynamically, listening to what content is sort of surfacing, what's important to them today. And I almost always find, and they could talk about something totally random that isn't directly related on the surface to the case conceptualization and their goals for psychotherapy. They'll mention something, seemingly random, and we'll go into it deeper, and then the same themes will come up. But it's a willingness to. I was listening to Irvin Yalom's latest book, which is phenomenal. So that's a pitch. And he has a line, you know what? It's a different book, which is also really good. But he has a line in this other book, I think it's Love's Executioner. He said, very nice for clinicians who have a modality they adhere to, and they believe that all of the questions that come into the psychotherapy room can be answered in line with that modality. That's a nice way to feel. But it's just not true. It's delusional. Right? We can't know. There needs to be, going back to what Yossi was mentioning this morning, there needs to be humility in the room, and the openness and willingness to embrace the not knowing, the uncertainty, and the anxiety that evokes. So,
what I'm hearing is both holding space for the client to listen to what the client is experiencing and to just give that space. And I think what you alluded to is also that within DBT, having even the treatment hierarchy and adhering to that is saying, I want you to be safe, right? We have life interfering behaviors, treatment interfering behaviors, and then, the day-to-day, which is saying, if you're coming in and I read in your diary card that, you were having suicidal ideation that week, I'm going to take that seriously. And I'm going to give space to it, I'm going to listen to it, but that's what we're going to spend time on because I care about your safety.
That's right, which I think is a really important thing, that no matter what, even within that space of giving space, there's still a psychotherapeutic frame. And there are certain things that take precedence because the clients, in order to work with somebody, they need to be alive. So.
And that feels very safe, right? Like for a client, that feels really safe to know that, right? Like I can take you on some form of meandering stream or come in with who knows what that happened this week that's seemingly important, but they know that you're there and you're going to redirect, reorient, or pull out the themes from what they're sharing. You get them, you know that. And that level of security is also really helpful. Like they know you're going to take them there. And if you don't, you're also doing them a disservice, right? That's the balance of both. If you just, I'm here for you, I'm listening to you, and then they walk out of session and say, well, that was an expensive 45, 50 minutes of my life, and I don't feel any better, which they'll say anyway, exactly, and make you feel wonderful. And they're good people, and they're not doing it to hurt you many times, besides for when they are. At the end of the day, that security is there, right, to be able to trust, that you'll be able to redirect and reorient them is really helpful as well.
Rachel, to you, I want to change the question just a little bit, which is when clients are coming to you, they sort of know what they're getting themselves into, but they also don't know what they're getting themselves into. I think there's a lot of trepidation, whether in trauma treatments or specifically with EMDR, that there's a lot that they don't know, but they know that they're afraid to sort of open that up sometimes. Do you feel like that's accurate?
Are you speaking in the context of EMDR work?
Yeah, within the context of EMDR.
Well, I mean, certainly within EMDR, as part of the phases of EMDR, it's talked about. So clients are not coming in, we're not pulling the wool over their eyes in any way. They know exactly, what they're signing up for. And we leverage that motivation. And that's, I don't think we really have the time to go into EMDR 2.0, where there's actually not an emphasis on safety and stabilization, because we're leveraging client motivation. You really want to be here. You've worked so hard and you've suffered for so long, and now you finally made it to this intensive program, and we're going to help you, and we're here, and let's do this. Yalla, let's go. And we just dive right in. It's a completely different emphasis than, let's say, somebody coming into my private practice for a more traditional insight-oriented psychodynamic kind of therapy. So yeah, the EMDR, it's part of the protocol. Clients have to be able to have the sense of safety of knowing what it is that they're engaging in. So yeah.
Few more minutes, so I'm just curious for your own experiences, because you all practice different kinds of modalities. What do you feel like are the misconceptions that sometimes get in the way of that DBT clinicians might have about trauma-informed care, or vice versa, and maybe how you sort of rectify that in your own work? You can think about it.
Sorry. I've heard people say, that they did DBT and it was superficial, and then they went over to something like IFS. And then I've heard the same thing in the other direction. I did IFS and it was good, it opened certain things up, and I just sort of stagnated there, so I went to DBT. And I think within the communities, it can be easy to sort of oversimplify the work that's being done. Psychotherapy, when practiced well, is not just a protocol. It's a relationship, it's an experience. So regardless of what modality you're using, it could be effective, right? Rachel, you were saying that what research has shown is that it's the relationship that counts for the most, not the particular modality. So I think to oversimplify, anything, DBT is just X, Y, or Z, it's DBT in the hands of this particular person. And that counts for the most. So I think that the danger is in sort of, reductionistic thinking, that this community only, puts the focus on thoughts, feelings, and behaviors. But we go much deeper. We go to the childhood roots. And the other is saying, well, they go to the childhood roots, but they just hang out over there, indefinitely. And we make real change. And I think that they, chaval to have a split. Rachel, this is something you and I have spoken about a lot. Chaval to have a split in the communities. Right? Paul Wachtel, I think in the 1970s, he had been trained as a psychoanalyst, and he started to develop an interest in behaviorism. And I think he was trained by Wolpe, or had what to do with Wolpe, he observed Wolpe, and was taken by the work and started to integrate it. And he came up, what he noticed was there was this major divide within the schools. And his thinking, I don't think he used this word, but was chaval. And what he started doing...
Definitely didn't.
He is Jewish, though. he tells a story of he was in a room filled with behaviorists, and he said to them, have you ever had the experience of really wanting to help a client? You knew just what was going to help them get from point A to point B, and they just wouldn't do it? Raise your hand. And they all raised their hand and said, okay, that's called resistance. Meaning, we're all dealing with the same phenomenological stuff, and we put different names to it, but there's so much more we have in common between the different schools than not. So I think that's an important thing for everyone really to appreciate.
Spoken like a true schema therapist. Okay, so I was waiting for that the whole time. Sorry. Okay, there is a lot of truth to that, right? So in my training, not all psychiatrists do training in therapy, by the way, anymore. People who are trained in the States, people who are trained here, much more often, the Israeli psychiatrists will be trained in psychodynamic psychotherapy. They will have exposure to CBT and DBT therapy, but they may not be trained. That's how the system here has worked for many years, and it still remains that way in most schools. In the US, there's just less and less total training, period. There may be certain residency programs will do like crash courses in like CBT for the psychiatrists. But so when I trained, there was someone who was a vestige of an old guard, so I still got to learn therapy, which was great. But he was highly psychoanalytic. He was a psychoanalyst, not psychodynamic psychoanalysis, like straight, which most people can't afford ever to do. So it was just interesting to hear from him. But as I progressed in our outpatient work, we did CBT therapy, classical CBT therapy all the time. And that's all that the residents were doing originally. And I kept going and going and going. And we started doing more and more case conceptualization psychodynamically. And then I said, I don't understand, because when I keep doing CBT, anytime we get to a client where the work's not working, CBT says to create this thing called genetic linking, and you go back to the past, and then I was like, wait a minute. This is all exactly the same thing, right? Exactly what you're saying. And they're like, and then one of my supervisors told me, she goes, David, because they couldn't pronounce David, yes, it is, but we don't tell anybody that because it's not going to work out well. And I was like, this is so silly. But anyway, but that's I think I 100% agree with you in terms of that. Which leads me, so I like working with all ages, but I really enjoy working with teens because they pretty much will tell you what they think and what's going on to your face, and they don't need to be in distress or trauma in order to do that. They'll just do it all the time. And so, like, an adult has to be upset to do that usually, but or other reasons. But an adolescent will just be like, no, DBT is not going to work for me because, like, I already know the skills. I'm not going to use them, right? And or they'll be like, well, trauma therapy, like, I already told my story like 17 times. I can tell it to you right now. I was X, Y, and Z happened to me when I was younger. I had this sexual assault, and this thing happened, and yes, I can put my hands in ice, and I can say special things, and my parents told me to say these 3 psukim 17 times, and then I'm going to be better, Dr. Haplern, right? That's what's going to happen? And I'm like, no, it's not going to happen that way. But the same thing, right? It's a general misnomer that people have that the therapies are identified by the buzzwords. And so if I did the buzzwords, I've been yotze zayin, right? I've been yotze the therapy, and I've fulfilled it, and now I've done my requirements. So I think that we, as clinicians, in whatever form that we are, need to tell people that whatever you think the therapy is, it's probably not that. That's probably just the most common and easiest way for people to identify the therapy as how it's different. Aside from even only just being there, like for the client and making that connection, the part that I think that people really miss a lot of the time is that the therapy has to be touching on the things that you would prefer to be better. Like that the reason why the therapy is therapy, right? DBT therapy means that there's a dialectic that bothers you that you're trying to fix, and you're holding that tension between those different things, right? CBT means there's a cognition you have that bothers you that you're trying to fix. Psychodynamic means there's a dynamic that you have that is not good that you're trying to fix. Those are the main focuses of those therapies. And I've never heard someone come into my office and tell me that was how, like, except someone who was already a clinician. Okay, so I've never had anyone else come in and tell me, oh, that was the therapy and it didn't work for me. So I think that's like one of the big misnomers. The second misnomer that this is my personal psychiatry pet peeve is that the assumption that I have to try therapy first. I know this is not a psychiatry piece conference, but I have to try therapy first, definitely before I do any medications. It depends on what is happening. And especially if you have a client where their level of functioning is impaired, all of the evidence says that there should be some shiluf, some combination of working together with somebody from a medication management standpoint. And if someone chooses not to do that, they should just be aware the evidence for them to improve significantly with just the therapy alone drops. It's not just like, oh, it's going to be a little harder. It's going to be like 20% harder, and that 20% goes from a 70% response rate to a 50-50 response rate. And then when they say, why did I pay for that session, like that's a legitimate concern.
I'll just add one thing, is that there's also a lot of information out there, and clients have also been through a lot of therapy. That's something that we're seeing often that comes into our offices, is that many times clients are coming in with, like you said, that laundry basket. So they also have a laundry list of therapists that they've been to or therapies that they've done. And I've tried this and I've tried that and I've tried that, and I don't even know why this is even helpful and why would you even be helpful. And they give you that pitch right there in the front. And so I looked this in this app and this is what was recommended, right? If they're coming from a referral agency or their best friend or their mother's brother's sister's dog, refer them to you because you practice this and this, and they're coming to you and they say the best classic line I heard last year was my client came in and she's like, hey, so you're going to do the thing? These were her words. You're going to do the thing, yeah? I said, what thing? Well, you're going to do the thing like that everybody said you do. I said, I don't know. What do I do? She's like, you know the thing, you know, like the it starts with the E. She didn't even know what the letters were, but it's some form of alphabet soup that she wanted me to do the thing in the room. This was before intake, before anything. There was so much in the room, but she wanted me to do the thing so that she could feel better and move on with her life. And so I think that there is so much information. There's a plethora of information out there, but there's also so little information as well. And so when we kind of can psychoeducate from the beginning as well as be flexible, like we're promoting flexibility and dialectics. And if we're going to come in and be rigid and say, oh, I'm a DBT therapist, or I'm sorry, I'm a trauma-focused therapist, or whatever it is we are, and a client needs something else, like that level of rigidity is really awful to model for a client that you're trying to promote flexibility, spontaneity, movement, creativity. Like, what are we servicing them with? So I think it's on us to be able to come with an openness and curiosity and creativity from a place that's like humble and curious to these great people out there who are trying to help themselves and live a life worth living.